Good afternoon, everybody. It's an absolute pleasure to be here, and welcome to today's ASLM Virology webinar, which is entitled From Policy to Patient Impact, Advancing Differentiated Service Delivery Through Decentralized EID and Viral Load Testing. I'm Gwen Stevens, and I'm a Senior Director in the Medical Affairs team at Cepheid, and I'm really honored to moderate this session. And thank you to all our colleagues from joining across Africa. Our focus today is really on closing the gap between policy intent and patient impact in HIV care. Over the past decade, differentiated service delivery, or DSD, has become essential to how countries deliver HIV services, making care more accessible, more efficient, and more patient-centered. But the effectiveness of DSD really depends on one critical enabler: timely access to essential diagnostics, especially when we talk about early infant diagnosis and HIV viral load monitoring. It's true that without fast, reliable results, even the strongest service models cannot deliver their full benefit. And across many settings, persistent diagnostic challenges remain. Long turnaround times, sample transport constraints, and backlogs at centralized laboratories really delay clinical decision-making and can negatively affect patient outcomes. For an HIV-exposed infant, weeks of waiting for a PCR result can really mean a delay in the start to life-saving treatment. For someone on ART, a delayed viral load result can postpone regimen changes and really compromise long-term outcomes. And in these moments, the chain from policy to patient breaks down. So decentralized diagnostics really offers us a practical way to bridge these last mile gaps. Point of care and near patient testing integrated within existing diagnostic networks can help us to reduce those turnaround times, simplify logistics, and deliver results when and where they matter most. Bringing testing closer to patients strengthens linkage to care and empowers clinicians with timely information, ensuring that DSD really delivers on its promise. So, in short, decentralized diagnostics help translate policy into measurable patient impact, so no patient is left waiting. So, today's webinar follows a clear narrative from regional context to the clinician, laboratory, and patient interface, and finally to national implementation. We'll begin at the patient level with Dr. Bandezi. We'll just check that Dr. Bandezi has joined us, and Joki, you'll just let me know. But if Dr. Bandezi has joined us, we'll start with her. And Dr. Bandezi is a seasoned public health clinician and strategist with over 30 years of experience across HIV, TB, maternal and child health. She's renowned for her practical integrated approach, and Dr. Bandezi will share real-world case studies demonstrating how effective lab-clinician collaboration and timely diagnostics directly improve patient management. We'll then turn to our Kenyan colleagues, and they'll take us through the Kenyan experience, translating policy into practice. Dr. Lazarus Monmani and his accomplice, Dr. Japheth Gituku, not Gitau, as you see on the screen there, so apologies for that spelling error. They will have a look at, the picture as we currently see it in Kenya. And, Dr. Lazarus actually brings over 20 years experience in HIV and TB programs and leadership in developing national HIV guidelines. And he'll outline how Kenya has implemented decentralized EID and viral load testing within its existing diagnostic network, highlighting program design, patient pathways, and lessons learned. And then Mr. Gituku, who's the program manager for infection prevention and control and laboratory commodities at LabCoP. He's a veteran laboratory scientist and a national trainer. He's really played a key role in operationalizing decentralized testing, including laboratory systems, commodities, quality, and sustainability. And he will share some practical insights from implementation at scale. So, in summary, we hope that today's session will show why timely diagnostics are indispensable to effective DSD and how decentralized approaches can bridge this last mile from policy to patient care, really from the clinic to the laboratory to national programs. And we hope you'll leave here with actionable insights for your own contexts. So, thank you again for being with us. Please share your questions in the chat as you go along, and we'll address them during the Q&A session. So with that, let's begin. And it's my pleasure to hand over to our first speaker. If somebody can just let me know whether Dr. Bandezi has joined yet. If not, Dr. Lazarus, we'll hand over to you.
Gwen, I believe Dr. Bandezi is not with us yet, so we can start with Dr. Momani.
Okay. So Dr. Momani, I'm going to hand over to you, and thank you very much.
Thank you so much, and good afternoon, good evening. My name is Dr. Lazarus Momani, as I've already been introduced, from the Kenya Ministry of Health, National AIDS and STI Control Program. I'll be making this presentation with my colleague, Japheth, who will be coming in a while. We'll talk through some of the parts of the presentation. Today, we are going to share with you our Kenyan experience in leveraging point-of-care technologies to scale up viral load testing, as well as early infant diagnosis, while focusing mainly on our implementation journey and some of the lessons learned along the way. So we really thank SLM and CFAID for giving us this opportunity to be able to share our work on this platform. Just start off with some disclosures that this presentation is being made on behalf of CFAID. However, the context that we'll be sharing reflects the Kenya Ministry of Health program experience and does not represent any conflict of policy interests. So we'll start off by just sharing a little bit of background, country background. As a country, we've made a significant progress towards HIV epidemic control, with an estimated close to 1.4 million people living with HIV in Kenya. Our country remains among the top 10 HIV epidemics globally, while through implementation of high-impact combination prevention strategies, you can appreciate that we've really made significant progress towards reduction of new HIV infections. However, we're still concerned about the slow decline of AIDS-related mortalities, as you can appreciate, over the last 6 years. And this really underscores our current accelerated efforts as a country towards efforts to address advanced HIV disease. So looking at the HIV cascade, you can appreciate that we've really made significant, again, progress with the overall cascade, especially among us adults, performing quite well. However, again, as you can appreciate, is that our children lag behind as per our data, the most recent data across diagnosis, treatment, and viral load suppression. And this really highlights a critical gap that requires targeted interventions, including scale-up of point-of-care testing, for us to be able to improve diagnosis and testing amongst this population. So looking at the viral load coverage, we've actually done very well in terms over the years towards improving viral load testing, as my colleague Japheth will also be highlighting. However, despite this, you also do still appreciate that we do note significant disparities across age, population, and even geographies. And in this slide, you can appreciate the wide variation in viral load uptake across counties. In Kenya, currently, we have what we call a decentralized system of health, where we have 47 counties. And you can appreciate that there's that wide disparity. We have noted challenges, especially in the hard-to-reach areas, which really highlights some of the inequities in access and also service delivery. And again, underscoring the need for decentralized solutions like point of care. So as a country, we've made actually very significant steps or bold steps towards integration of not only HIV and other services, but also in terms of system integration towards a person-centered care. So you can, from our 2026 guidelines, you can actually see that we now have one single guideline that addresses issues around HIV, STIs, viral hepatitis, non-communicable diseases, and other diseases of interest. And in our recently launched guidelines, again, we have clearly underscored the importance of viral load testing as a gold standard for monitoring people living with HIV on treatment. We have also clearly articulated the need for scaling up of point-of-care technologies for specific populations and some of the geographies, including those of hard to reach, to be able to improve access. So just giving a little bit depth of what our guidelines really recommend in terms of viral load testing. We are using a differentiated approach, which is depending on age and population. And as you can appreciate from this, we are doing a first viral load at 3 months, but then after that, we have more frequent monitoring for children and pregnant and breastfeeding women. And this clearly increases the demand for accessing testing service, viral load testing service in these populations, with the need for early return has been pointed by the early speaker, and timely clinical decision making. Hence, again, the need for scaling up of point of care technologies to be able to close that gap and improve access and return of results. Over the years, again, as a country, we have really put a lot of emphasis around the issue of triple elimination of HIV, syphilis, and hepatitis B elimination amongst pregnant and breastfeeding women. We over the years, we've also really developed a very strong infrastructure to be able to improve early infant diagnosis through the molecular technologies. In our 2026 guidelines, we have made a significant update to now move towards universal birth testing for early infant diagnosis. And also, of course, as you can see, followed by multiple testing at 6 weeks, 6 months, 12 months, and at 18 months. And this clearly increases the demand for rapid decentralized testing for this population. As you know, return of results, early return, and it really improves initiation of ART, preferably on the same day for children who are HIV infected. And really, this is where we see, again, point of care technologies really coming in to be able to help us to be able to enforce or to operationalize this new guidance. So at this point, I would like to welcome my colleague, Japheth, who's going to talk us through some of the efforts and the journey towards improving or leveraging on point of care technologies towards improving viral load and early infant diagnosis. So Japheth, please take it over from here, and I'll come towards the end.
Yeah, thank you very much, Dr. Mimani, for taking us through that part of the first part of the presentation. I'll take it up from there. I take you through the journey to the scale up of gene experts, the point of care diagnosis. Then I'll take it back to you for summarization. Let's go to the next slide. So, on a bit of introduction, I think I was introduced. My name is Japheth Kituko, working with the Minister of Health. So, I'll set up a roadmap of point of care diagnosis for EID and viral load. So the point of care scale up for EID and viral load started the year 2015 with some funding that Kenya got from UNICEF through EGPAP. So that is where the journey started in 2015. And there was an expansion in 2016 through UNICEF and through SHI, which accelerated the innovation for point of care diagnosis for EID, and we are leveraging on the existing infrastructure for gene expert for TB, which is support the TB program. And this basically we were targeting the hard to reach areas and hard to reach areas. So from 2016 to 2025, we did not have there was a funding gap, but we got some funding from the Global Fund, Psycho 7, to support the procurement of the cartridges, and we had to start the procurement and training of the healthcare workers to continue testing for EID and viral. So we started in 2025 again, And in 2026, we are planning to scale up more point of care sites to support the EID and viral testing. Next. So for viral and EID capacity for the convention, we use both conventional testing and point of care diagnosis. For the conventional testing, we have 15 labs, and out of 15 labs do the viral and viral only, and 9 out of the 15 labs they do the EID testing for the conventional. In terms of the POC, we have 76 sites for both EID and viral. For the GeneX, for the point of care, we have two types of point of care tests that we use. And the gene expert, you only use it for EID and viral, and we have that 3 sites. And for MPMA, we only have 43 sites, and currently we are only using the MPMA for testing the EID. You can see the map of Kenya with the key sites that are, these are sample referral sites, especially for the counties and the labs where they refer their samples. Basically, this just show you where the labs are and the sample referral networking. This is just a summary of how the sample referral networks are actually good to the labs. Next. So for point of care, you can see the year 2026 where we are in the map of Kenya with which is in the left-hand side with the 33 gene expert site and out of and 43 MPMA sites. And also, in addition to that, you can see we have about 15 labs which are testing for EID. Out of all those, you can the next map, which is on my right side, just show you where exactly the gene experts sites are. They are spread across the country, but you can see where they are concentrated more. It's where the HIV prevalence is, especially the Nyanza region. That is where we have the high prevalence. Where you see we have different platforms. That is where we have a low prevalence, and that is those are the hard-to-reach areas, especially the northeastern part of Kenya. That is those are the hard-to-reach counties where they are located. That last year, I said in my previous slide that we embarked on the point of care diagnosis for EID because we got some funding from Global Fund Cycle 7. So we embarked and we did that some refresher training. We did the training one focusing on viral and EID, focusing on the 33 sites, basically looking at the EID and viral for the 33 sites. So in the second part of the training, we used the training to target the facilities that are both EID and viral. They're testing for EID and viral, and they can test for other viruses like hepatitis HPV, hepatitis C, STI. We are procuring even the CTNG to test for chlamydia and trichomatitis and also Neisseria. So we focused on the second training on those other sites that are not specific for EID, and they can also support testing for these other tests. So that is how the levels of the training we conducted, training 1 and training 2. So in terms of the performance, the total performance of the year 2025, we did about 1,094 tests for viral. Out of those, 1% of those tests were done using the point of care, and that is basically the feed type of the gene expert. And the total, I said we have a total of 33 point of care sites that are currently active to perform the VL and EID testing. So every year we do our annual forecasting and quantification, and we project for about 3 years. And projection is in the projected testing target are applied based on the approved national testing algorithm and guideline. So when you are doing our F&Q forecasting and quantification, we look at our algorithm. What does our algorithm say? What are our guidelines saying? Like now we have revised the new guideline, and this year we had to factor in the new guideline in our annual forecasting and quantification. So we also look at the new technology. Do we have new technology in place so that we can factor those technologies when we are doing the forecasting and quantification? So out of our quantities we did this year, we did 2025 and 2026, 95% were to be done, tests were to be done using the conventional equipment, and the 5% split was supposed to be done using the point of care equipment. In 2027, again, we had to increase these quantities. For conventional is 90%, and also the point of care diagnosis, we are doing 10%. That is 2026 and 2027. So of course we cannot do all those things we have done without some factors that are attributed to the success, the scale up, and one of the factors that contributed to the scale up is the strong coordination leadership. That leadership at the national level and the county level. Of course, there was buy-in from the county government in terms of scale up of these technologies, and then there is issues to leadership commitments. Strong leadership for both national and county level drives the implementation of policies and strategies. And then there was effective commodity management, accurate forecasting and quantification, and also supply chain optimization. There's also issues to do with timely review of and utilization of guidelines. When the guidelines are reviewed, we have to utilize them in time. And of course, integrated stakeholders engagement on the diagnostic network optimization for multi-disease testing, leveraging on available resources. The other thing is the effective sample networking and efficient sample collection and transportation. And also samples are logged in remotely from very far places. The samples, you can see they are being logged in. So there are still some gaps in as much as we have success story, we still have some gaps in terms of infrastructure and equipment. Of course, they are limited in terms of coverage. We have not covered the country the way you're supposed to cover. There is issues to do with the equipment breakdowns. They are still there. And then there is the supply chain issues. Of course, as much as they see there is issues to do with annual forecasting and quantification, of course, there is inconsistent supply of reagent and consumables due to budget constraints. As much as we say that we are going to procure 100%, with the available resources, we have to prioritize and maybe reduce the number of tests we are going to procure. Other things are logistical challenges, efficient sample referral networking system, and referral networking leading to delay in testing and return of results, especially to hard-to-reach areas. In some other areas, this is not a challenge, but in hard-to-reach areas, transport mechanism is a big challenge. Of course, there are issues to do with human resource, and one of the areas we are looking at is the shortage of trained personnel due to high staff turnover. So what are our plans? Our plans for this more decentralization is normally guided by a diagnostic national network optimization. That's the DNO report. In Kenya, guided the process of decentralization, and it proposed one of the things it proposes is scale up of decentralization of point of care to hard-to-reach areas. More decentralization as a country we are going to do in the future because we are leveraging on some funding, and we will be able to do more decentralization on hard-to-reach areas. Of course, we have to look also to the counties experiencing highest unmet testing needs. We have those counties which are experiencing unmet needs, and we have to target them. We have special population we have to target also, and those special population, including pregnant mothers, migrants like refugees camps, and also those who are in poverty settings. And the last thing is about islands. Those include Mfangamano Islands, Wasi, which are in the Victoria Basin, and Kizigitini. Those are the areas we are targeting that more scale up. We are going to do more scale up based on the diagnostic optimization. I think that is the last slide. I take it back to you, Dr. Lazarus.
Okay, so thank you, Japheth. And I think so as we try to bring the presentation towards the end, just wanted to highlight a few things. I think Japheth has really done good work just highlighting our journey and just showing that scale up of point of care technologies is a process. It takes time. It is investments of resources and also applying some of the lessons learned. So I think in summary, we just wanted to point out that these technologies, of course, you have seen that they do work and they are feasible, and they'll be very critical towards closing the gap. Some of the populations have been mentioned, but key among us, this is really integration, not only in services, but also programs. And for us in Kenya, we have seen that actually working with some of the programs like TB program, for example, now we have really quarterly meetings with them, also including commodity planning and also the lab, just trying to figure out how we can be able to use the resources on both sides of the program, with the VH program and other programs like the NCDs. The other thing that we've also seen, of course, is important that we are also learning. So there'll be importance of just investing in some level of operational research, just to be able to see what works, what can be improved, and what can be scaled, and what is the best way of scaling. And finally, of course, noting that HRH still remains critical. There needs to be continuous training on the new technologies, and to ensure that there's no interruption of services even as we scale up. And then finally, the issue of resources. So for us, we also just trying to look beyond the external sourcing, just to see what kind of domestic resources can be put in, even in the context of universal healthcare, to be able to secure this technology and ensure that we don't have scaling up and then future interruptions when we run out of reagents or servicing of the machines and so on. And therefore, even also trying to advocate for counties which have the resources to be able to allocate in terms of servicing and improving continuity of testing using these resources. So just to end, say thank you. And recently, as a country, we had an integration summit that brought in a lot of players, including our partners, our funding partners, and everyone on board, just to be able to discuss. And one of the key resolutions was that really we are moving towards integration, not only of services, but also of systems. And this is really a way for us to go. And we hope that using some of this goodwill, political goodwill, and also some of the resources that have been put in place, then they'll be able to see scaling up of these technologies towards improving patient care. So thank you so much. And we welcome any questions to be able to respond. Thank you, and back to you.
Thank you so much to our Kenyan colleagues. And in the interest of time, I think Dr. Bandezi has now joined, so we will go straight to your presentation. I did introduce you earlier on in the session, so I'll hand over to you, Dr. Bandezi. There have been some questions on the chat for Dr. Lazarus and Dr. Jaffet. So I think I've tried to answer some of them. But, maybe I can ask Dr. Lazarus one question. If there was one key lesson that you have learned in this process of scaling up that you would like to share with other countries who are thinking to do similar things, could you tell us what that would be? Dr. Lazarus, you're on. Yes. Okay.
Thank you. Yeah. So I think if there's one lesson, it's just I would say it's just long-term planning and bringing all key stakeholders on board. So because just like the way Japheth mentioned, that at the beginning, you saw that the introduction of point of care in Kenya was done as a pilot that was supported by United, of course, with the in-country support from CHAI, and also ECPAF. And what we saw is that while there was success and the pilot was able to demonstrate that there was very clear benefits in terms of improving early identification, improving early return of results, improving linkage to treatment. However, we saw that once the project came to an end, then some of those technologies they were not able to work beyond the project period, because there was no clear planning in terms of transition from the funded project towards country-owned resources that were able to support, for example, purchase of reagents, servicing of the machines, and so on. So I would say that I think there's need to, as we scale up, to ensure that there's that, first of all, there's in-country policy that supports scale up. And for us in Kenya, we've been very clear about ensuring that that's a strong policy that clearly articulates that there's need to scale up a point of care, but most importantly, involvement of all stakeholders in terms of long-term planning and ensuring that there's clear transition planning, either from pilot funded projects or from externally funded platforms towards in-country resources. Thank you, and back to you.
Thank you, Dr. Mamani. That was very helpful. I think it's all about ensuring that you have, support from the top down. I'm just checking in with Francis to see if Dr. Bandezi has sorted out the technical issues and whether we will run with her or we continue with some Q&A.
Good afternoon, colleagues. My apologies. My presentation today is from results to impact, specifically looking at lab clinician collaboration. I would like to disclose that I'm doing this presentation on behalf of KFIDE. So just as a brief overview of the presentation, we'll just go through the introduction in terms of basics, specifically looking at WHO approach and the South African context of the case studies. The case study specifically at early infant diagnosis of HIV-exposed infants and early infant diagnosis of HIV-infected children. Specifically looking at linkages, today we are looking at the lab and clinician collaboration and how do we at individual or institutional level make sure that those linkages are strengthened. Back to basic, we come from a background of always taking a history, clinical examination, and what is the summary of the problem. Today, we are talking about a pregnant woman and would like to prevent transmission of HIV from the pregnant woman to the baby. And I would like to emphasize that in the context of today, investigations are always part of management. Why are we highlighting that? Behind a specimen, there is always a patient, and the clinical outcome always depends on how soon is the problem identified and access to appropriate intervention, and more importantly, timeless intervention. So if we look at the background in terms of the 4 prongs of vertical transmission from the WHO approach, I'm going to focus mainly on the 2 points on this particular slide. The first one is primary prevention to reduce infections through testing. We are talking about an we're talking about a pregnant woman, primary prevention of new infections. The last one is to make sure that we have got appropriate care of pregnant women, the infants, and the children through prompt testing and intervention. In the South African context, it's still along the WHO guidelines. I will focus on primary prevention. The third pillar is prevention of transmission, and the fourth pillar is appropriate intervention. So if we look at mother-to-child transmission specifically, we have come a long way from the early 90s and 80s, where we knew that 15 to 45% of HIV-infected women transmitted HIV to their babies. Through impactful models, including effective lab clinician collaboration, we have had a lot of innovative programs, and according to the UNAIDS report of 2025, 44.4 million HIV infections were prevented between the year 2000 and 2024. However, in terms of the global health sector strategies, we are no longer talking the numbers in the thousands, in the hundreds of thousands. We are saying let's follow each mother and baby pair so that we can eliminate HIV transmission and the number of 0 to 14-year-old children living with HIV. The target for 2030 is 15,000 children. Now, in terms of today, we are focusing on lab clinician collaboration. The most important thing, as I've highlighted earlier, is individual personnel that will translate to facility and country by country. What is important is to identify that women along the care pathway from the time a woman of childbearing age wants to have a baby until that baby is born. So we are going to look at the first case study, specifically looking at early identification of HIV-exposed infants. And it is very important to be cognizant of the infants at a higher risk of acquisition. So we need to identify HIV-infected women of childbearing age. We also need to identify maternal seroconversions. So I will start with the first case study. Nancy, a 28-year-old para-0, a pregnant woman for the first time, who's married and who presented a primary health care facility in South Africa, Facility X, for her first antenatal care visit at 8 weeks of pregnancy. She's excited about her pregnancy. She recently got married. At 34 weeks, the HIV rapid test at Facility X, the primary healthcare facility, is inconclusive, and according to the South African guidelines, the specimen is sent to the lab for ELISA. The ELISA also came back inconclusive, and the results were sent back to the facility as usual. She missed her 36 weeks ANC visit for personal reason, and she delivered at 37.5 weeks at a community healthcare center. The delivery was uneventful, and she told the midwives at the facility that she tested HIV negative throughout her facility. She was transferred back to the primary healthcare facility for her postnatal visit and EPI visits. She presented at Facility X for her postnatal visit, doing well with the baby. The attending clinician noticed the HIV results from 34 weeks that were inconclusive, and she requested to repeat the rapid test, which came back positive. Devastated, as she had tested negative throughout her pregnancy and confused, she reluctantly agrees for her baby to be tested, and the PCR results came back positive. Now, the highlights at individual levels and as the clinicians is to look at what could have been done better in the management of this pregnant woman, and also identifying her seroconversion early on. Had it been identified at 34 weeks, maybe the results could have been different. So the point from this case study is identifying maternal seroconversions early. That would mean that the HIV exposed infant would have been identified early, and the infant would have received appropriate intervention timeously. So the most important thing is here we need to identify HIV exposed infants at high risk early. Here there was a late maternal seroconversion, the mother was not put on treatment, and as such also the baby was not given post-exposure prophylaxis in terms of HIV. So in terms of the testing, all HIV negative women, they need to be tested regularly. And the important thing here is not to just look at the test and the results can always be sent at the facility at any time. It's to look at the results and intervene timeously and appropriately. HIV positive women, they need to be counseled and initiated on treatment very early on. So in terms of the retesting of HIV negative women from the South African context, it's regularly throughout pregnancy. They are tested again during labor and delivery. They are tested at every EPI visit in terms of the mother-baby pair. Please do refer to your country guidelines. It is important that you are all familiar with the guidelines and we implement them. But the most important is not just to do investigations and forget about acting promptly in terms of the results of the investigation. Also, more importantly, is follow-up care that is appropriate. So in terms of clinician lab collaboration, what are the lessons learned from this case study? Is that HIV and HIV negative women may seroconvert at any time during pregnancy as breastfeeding. So we do give HIV prevention messages. We also know that during seroconversion, the viral load is usually very high. The higher the viral load, the higher is the risk of transmission. So at lab clinician collaboration, attention to indeterminate HIV results or inconclusive ELISA results, it is very important to make sure that there is appropriate follow-up, there is retention in care, and more importantly, there is communication between the laboratory and the clinician and the clinical side. That is the lab personnel and the clinician. Now let's go to case study 2, is again early identification of HIV exposed infants at risk, specifically unsuppressed maternal viral load. Melissa, a 32-year-old, para 1, gravida 2, presented at Facility X. He was known, booked early, known on treatment, reported good adherence, and the viral load request was sent to the lab. The viral load came back with 5,373 copies. The medical technologist called the nurse at Facility X as the viral load was not suppressed. Melissa, adherence counseling was done, and repeat viral load was done. As you can see, there is a decrease in the viral load. However, if you look at the log value, the decrease is not substantial. So now the medical technologists, again in this case, called the facility, and a community health worker was sent to Melissa. Melissa was counseled and changed to the second line regimen. The rest of her pregnancy was uneventful. Repeat viral loads were suppressed. Melissa delivered a baby girl at 37 weeks. The baby was given post-exposure prophylaxis. The baby was exclusively breastfed and tested negative up to the age of 18 months. Now, the question there, if we look at case study 1, if in case study 2, there was no good collaboration between the laboratory and the clinician, what would have been the outcome in terms of this baby? Now, HIV-infected women that are newly diagnosed or HIV-infected women that are on ERT, the viral load should be monitored closely. Again, I would say please refer to country guidelines in terms of monitoring of pregnant women and breastfeeding women in terms of the viral load. We need to encourage women to return to the facility, and communication is important in terms of retention in care, and make sure that our women understand the follow-up plan throughout pregnancy and throughout breastfeeding. We know that a high viral load is equal to a high risk of transmission. When the viral load is unsuppressed, it cannot be business as usual. Follow-up and interventions are important promptly according to the level of the viral load and also following the country guidelines. Now, for HIV-exposed infants, it is also important to identify those children that can still be infected with HIV in order to reduce the impact of HIV and the AIDS epidemic by 2030. Whenever you see the mother, it's important that you think baby. Whenever you see the baby, it's important that you think mom. Now, let's go to our third case study, Fungi, a 35-year-old non-HIV-infected woman who also booked at 12 weeks already on treatment. The viral load was suppressed at booking, had an uneventful pregnancy, delivered a term with suppressed viral load. Her baby tested negative at birth and at 10 weeks. She lost her husband at 5 months post-delivery. Her mother and the mother-in-law, they came to stay with her, and they told her that she must give her baby solids as she was stressed and she did not have enough breast milk. She came to the clinic alone at 6 months for her viral load. She confirmed that she was still breastfeeding. She also highlighted that coming to the clinic was tricky as she was still in mourning. She also reported that she was taking herbal herbs for cleansing as part of the bereavement and the mourning. The viral load request was sent to the lab with the history of PMTCT on the request form. The viral load came back as 1,673. The results were sent to the facility as usual. After 3 months of mourning, Fungi was allowed to travel freely. She remembered the information that she was given that she needed to go back to the clinic for her 3 months viral load and immunization of her baby. The clinician noticed previous viral load results. Adherence counseling was done. Fungi reported good adherence and she had stopped the cleansing herbs a week ago. She also highlighted that her mother and the mother-in-law had left her space and she was in a better mood. A repeat viral load that was sent to the lab was sent on the same day. However, it is important that there was a missed opportunity in terms of 3 months had passed since the last visit. The repeat viral load came back as 47,015. Now, the medical technologist called nurse at the facility X. However, in terms of the mother-baby pair, as much as this was discussed at this visit and an urgent PCR was done, there was a missed opportunity at the previous visits and also not paying attention to the other psychosocial history and the fact that Fungi was taking herbal medication. The PCR came back indeterminate. Fungi's viral load came down, and there was a log decrease as well of more than 1. The baby was started on ART on the same day. A repeat PCR and viral load was done. So the lessons from this case study is that whilst the second viral load, they were in the second viral load, there was good lab clinician collaboration. There were missed opportunities with the 6 months postnatal visit and the first viral load. At the facility, the point of care, at the lab as another point of care, and again as the facility as another point of care. Again, Fungi was in mourning. We need to start thinking about what can we do at community level as a point of care. In terms of the HIV exposed infants, in the South African context, testing is done at 10 weeks, at birth at 10 weeks, and again at 18 months. The other children, it depends on the post-exposure prophylaxis that the child was done. If the child was on an extended prophylaxis, the testing will be done 4 weeks after the exposure prophylaxis has been stopped. The other one is an age appropriate after cessation of breastfeeding, and at any time the child is symptomatic or at the discretion of the clinician. In terms of other infants, we need to remember the orphaned or abandoned infants, and the non-breastfeeding infant will not be given prophylaxis if the infant presents late. More importantly, in terms of PCR is indeterminate results and how do we manage those indeterminate results. In terms of the women move through facilities from a primary healthcare facility to a delivery facility. Often at the delivery facility, the woman is discharged before the PCR results are available. What is important is communication with the receiving facility at primary healthcare level. Also important is the information that is given to the mother about the follow-up plan and ensure that we have got the contact details of the mother. Any infant with a positive PCR must be urgently referred and discussed telephonically with a senior clinician for initiation of treatment. Remember, we want to reduce AIDS, the impact of HIV infection in terms of the AIDS epidemic by 2030. It's important that, again, the indeterminate results should be discussed with the senior clinician and treatment should be, or intervention should be started promptly. This is the South African context in terms of what is the response to PCR results. The wish is to have a negative PCR throughout breastfeeding up to the age of 18 months and throughout the life of the baby or the child. The positive PCR, it means initiate the ART soonest. The indeterminate PCR, in terms of the South African context, and I think WHO recommends the same, is treated as if the child is HIV negative. So you'll repeat the PCR and you'll do a viral load on the same day and discuss with a senior clinician. Now, the take home here is that we need to make sure that we strengthen the linkages in care along the pathway of a woman of childbearing age, and specifically in terms of vertical transmission and HIV infected women. It's important that we avoid the weakest link and we adopt a patient-centered approach. What does that mean? We need to educate our patient. We need to make sure that our adherence support is patient-orientated. We need to ensure that we have got appropriate documentation. The clinicians, when they are sending the lab requisition form to the lab, it is important to write the complete history and to indicate that the woman is part of a PMTCT program. When in doubt, this is where we need to strengthen between the lab and the clinician. We need to be able to have models of communication between the facility and the clinician. It is easy in terms of a private setup. However, in a public setup, there needs to be modalities of how does the lab communicate with the point of care at a clinical site. So I've just mentioned, this is a repetition, that the facility needs to have clearly recorded patient records. Patients, again, we need to know that they move from facility to facility. We also need that they acknowledge that the care of a patient, the specimen will move from the facility to the lab, and then the results need to be communicated from the lab to the facility. Urgent referral or telephonic discussion of results is important, and more importantly is the linkage to intervention. So what are some of the lessons or things that we need to do differently? We need to avoid loss to follow up because it is starting to threaten the success of the PMTCT program. In terms of the clinician lab, we all know that when a specimen is taken from facility X, it will be transported to lab X. So those referral pathways are clear. However, we need to start thinking about how do we enhance the communication channels between the lab and the facility and the turnaround times in terms of the specimen collection and appropriate intervention. We might think about the lab clinician rapid response or task teams with clear terms of reference, especially in a public sector point of view. We need to strengthen community care. We need to start thinking about innovations where specimen collection is done at home, again with clear standard operating procedures where that is necessary. We need to encourage participation of lab technologists, even clinicians, in morbidity and mortality review meetings. We should not only focus on the managers of facilities or the pathologists. We need to also encourage the testers to be part of these meetings for context and for innovations. We need to encourage lab personnel and clinicians to participate in continuous quality improvement initiatives in peer review or as quality assessment at local level as opposed to responding to managers or site visits. If all of us, we are strengthening the linkages and we are not doing things as usual, we will definitely see improved patient outcomes and elimination of mother-to-child transmission by 2030. I will end by saying together we can, and I would like to acknowledge some of the pictures from the National Department of Health training material. Thank you.
Thank you, Dr. Bandezi, for that really great presentation. Apologies to everybody for the late finish of this call. Unfortunately, we won't get to the questions, but we will address them. The ASLM will ensure that we get the questions and we will feed back directly to you. So it remains for me just to thank our speakers, Dr. Momani, Dr. Gituku, and Dr. Bandezi for your participation, and thanks to the audience for listening to today's session. I wish everybody a great day forward. Thank you very much. Bye-bye.